can forget. And I'm going to pause and let Stacia Stribling, our administrative and training coordinator, welcome you as well.
Hello, welcome this evening. I am Stacia Stribling, the Training and Administrative Coordinator for Formed Families Forward. I am the person that continually sends you lots of emails and reminders. So I'm really glad that you all made it here this evening. And I will be the person that you contact should you want a certificate of attendance for this. So as Kelly talks a little bit more about our organization, I will be throwing some links into the chat. So check those out as well as she gives you some additional information, and welcome.
Yes, welcome. We know that it is a busy time. We are in the Northern Virginia area, sort of at the semester break time. So I know things can be a little hectic. We are thrilled that you've chosen to spend time with us here this evening live or in recording later. We at Formed Families Forward operate a family-led resource center really focused on Northern Virginia foster, adoptive, and kinship families who are raising children, youth, and young adults with special needs. We also work hand in hand with the professionals who serve our families. We do our work through the offering of free trainings, free consultations. Those are typically one-on-one through Zoom or in person. Lots of events, lots of resources, and we work with families to navigate the systems that they may be trying to use to benefit their children and young adults. We have great support groups, peer support groups for youth and young adults. We have some for parents, caregivers, and we have some specifically for kinship caregivers as well. We'll talk a little bit more about those, but just know that we have a variety of services and supports available. And we have lots and lots of resources on our website. We also have the honor of being the family partner to the Virginia Tiered Systems of Supports Project, which is a Virginia Department of Education project. This is, as I mentioned, the third of our FASD winter webinar series this year. Next week is our final one, and we're really excited to welcome Lucy Bennell from the Northern Virginia ARC, the ARC of Northern Virginia, to talk a little bit about FASD and law enforcement, and that includes the courts as well as sort of our police and sheriffs. So she is going to enlighten us with some great ideas and helpful hints. So if you are here, you are already registered because it was a one and done. You registered for any of the webinars and we will send you reminders for all of them. So just know that we would welcome you next week at the same time. In addition to our FASD series, we have a number of other webinars on different topics this winter and spring. I'm not going to go into great detail, but I know Stacia will be placing the links in the chat. And we encourage you to register for those. Those you do have to register for individually. One coming up on language and speech development, as well as pragmatic language. We have another focus on transitioning young adults through a panel presentation. And then we have one specifically on issues around foster care. We also, you may have noticed we didn't have anything scheduled for April in our webinars, but we do have a fabulous event, and that's our annual Spring Forward Family Fun Day. We are thrilled for the 11th year to be welcoming foster, adoptive, and kinship families, and we have a really fabulous keynote speaker, Jessica Sinarski, who is an author and trauma expert. She has written the Riley the Brave books for children, which you may be familiar, and really has a very brain first way of talking and thinking about what our kiddos bring to our families and what we can do to support them. So I encourage you to join us out at the GMU campus in Manassas, the Science and Tech campus. All the families welcome. Babies, toddlers, children, teens, young adults, parents, caregivers. We encourage you to check it out. Registration is now open. And if you would like to get a little more information on FASD, on any other topic that might be of interest, we have a huge array of courses online that you can access through what we call Learning Your Way. It is an online self-paced course selection. It opens tomorrow. Registration opens tomorrow, and you can access those through June. And it's just a nice way of, at your own on your own schedule, on your own terms, getting a lot of information. They're a little interactive. There's some little quizzes and different things that you can access. And we do provide certificates of attendance if that could be helpful to you. I mentioned support groups. I'm not going to go into detail because I know Stacia is going to be linking these in the chat box. We have a youth and young adult support group that has just gotten started for winter. We have 6 more sessions. So if you're youth or young adult would be interested, let us know. It is in person and it is in Fairfax. We have parent caregiver support groups as well, 1 virtual a month and 1 in person. And again, I know Stacia's going to be linking that in. And finally, a reminder that if you do need a certificate of attendance, as Stacia mentioned, she is the person to contact. You have to be here now, live, to get that certificate of attendance. If you're watching this in replay, I'm sorry, but we are only able to provide those certificates for those who attend the live session. And you can contact her at stacia.stribling@formedfamiliesforward.org. We encourage you to check out our website, formedfamiliesforward.org, for lots and lots of resources. And then our social media is a great place to keep up with our own, as well as other partners and community activities that are happening. So Instagram and Facebook, and we welcome you. At the very end, we are going to put a link in the chat for an evaluation, a very quick online evaluation, but it really does help us know if this was helpful to you, what you would like to hear more of. We have Molly back because she was such a popular hit in previous years. So we really do use the feedback. In addition, we are funded largely by grants, and that helps us make the case that foster, adoptive, and kinship families can benefit from specialized services and trainings like this. And I think that wraps it up. And I am going to stop sharing and invite Molly to share. And again, we will try to make some time at the end. I think Molly has planned a few minutes at the end at least. But in the meantime, you can absolutely chat your questions in, and Stacia and I will help organize those and get those to Molly as she goes. Dr. Millians, thank you again for joining us, and we're going to let you take it away.
Can you still see me? Because I just
Yes.
quit. Okay.
Yeah, you're good. You may want to do the presentation mode.
I think I did.
So try that again. You were sharing and then you stopped.
My Zoom quit.
Oh.
As that is rebooting, I will just tell you real quick, I just put a link in the chat for the landing page that will give you the PowerPoint slides. So you do not need to write vigorously everything down. You will have access to those through that link. At the conclusion, probably tomorrow, I will send a link to the recording of this, and that will also include the slides as well if you don't get a chance to grab them tonight.
Okay, so Molly, we can see your slide and the one coming up and any notes that you might have, but this is fine. If you're comfortable with that, we can go with that. Oh, I think we lost Molly. That'll be tricky. We have her slides, but we don't have her.
I just readmitted
I apologize.
her, so
my Zoom just keeps quitting. All right. I can't, it's all messed. There we go. Can you see the slides?
We do. We see the slides and the next slide in line. Oh, now we don't see you. Are you still there, Molly?
Yeah, I don't know what's going on.
Okay, we can figure out how to share the slides.
Yeah, I think it's gonna have to come from your end because I'm having a lot of problems.
Okay, Stacey, do you want to share or do you want me to share? What's easier?
sorry, I can do that. I'm gonna go grab them right now.
Oh, I have them. Why don't you let me do that, and then you can
Okay.
manage the chat box.
Sure, no problem.
Oh, wait a minute. I think I got it.
Okay.
You see it? Is it working?
No, not yet.
Oh,
I'll give you a minute more and see if you want.
I am so sorry.
That's okay. We're good.
anyone who is here to learn about FASD knows that
It's not,
going
I'm
with the
sorry, it's not
flow.
working.
That's okay, Molly. We'll go ahead and share for you.
Okay,
That's
thank you.
okay. Have you got it, Kelly?
It's been a little pokey. Maybe it's the slides and it's not any of us. Let's go with that. Oh, yeah, okay. All right. Yeah. Nope, nope, nope. In there. How's that?
There we go.
Okay, take it away, Molly.
Thank you. I apologize, everyone. I'm Dr. Molly Millians. I am the clinical education specialist with the Emory Neurodevelopmental Exposures Clinic at Emory. At Emory University in Atlanta, Georgia. We're going to talk tonight about interventions for school-age children with FASD. We go on to the next slide. A brief kind of overview of who we are. We're part of the Center for Maternal Substance Abuse and Child Development. We are part of the Department of Psychiatry at Emory. Since 1980, Dr. Clara Coles has led us. We're kind of a three-pronged approach. Our services are covered by a grant through the state of Georgia. We do Mother to Baby of Georgia. This is a teratology warm line where professionals and families and pregnant women can call in if they have any concerns about prenatal substance exposure. We try to answer them and give them any recommendations and referrals within their area. The clinic piece is the Emory Neurodevelopmental Exposures Clinic. We do diagnosis for effects from prenatal alcohol and other exposures, as well as interventions and treatment. We also do research. And I'm going to talk about two of our intervention programs that we have published. One is the Math Interactive Learning Experience, and one is Go Far. So we'll talk a little bit more about that throughout the talk. Before I get farther, I'd like to kind of acknowledge those who fund us. We are funded through the Georgia Department of Behavioral Health and Developmental Disabilities, the Health and Human Resources Administration, NIAAA, the Collaborative Institute on Fetal Alcohol Spectrum Disorders. Some of our research is funded through them. Otis, which is where our Mother to Baby is funded, and we'd like to give a big thanks to all the families who participate with our projects. So there are no conflicts of interest to disclose. The objectives for this talk, and I noticed when I was looking at there was a typo. We're going to examine the perspective towards interventions for individuals with FASD. We're going to review a framework when considering interventions, and we'll talk more. You'll hear a lot lately about strength-based approaches, and I'm going to try to take it into a little more to be a little more specific. And then we're going to look at evidence-based interventions specifically designed for children with FASD, as well as those designed for other learning disorders. So let's talk about perspectives or approaches for interventions. When we talk about PAE, there's an impact or what we call about burden of care. Individuals affected by prenatal alcohol exposure or FASD, and I'm going to talk about FASD and prenatal effects from prenatal alcohol exposure interchangeably. They may have lifelong problems, not only in physical and health, but in development and cognitive aspects, behavioral and social, and academic and vocational. When we talk about physical health and motor, we're talking about some have cardiology issues, have other physical conditions that need to be cared for, and these are long-term, and we know that from studies into adults. When we talk about developmental and cognitive, we're talking about specific development throughout time on their learning, how well they learn, executive functioning, other cognitive impairments that might change over time, might improve, and how to support them. That might mean special education services, vocational services. We might need speech and language therapies, occupational therapy, and other kind of support services. When we talk about behavioral social, they may need, in this case, interventions to address some challenges with behavior problems. They may need psychiatric services. They also may need other supports at school, as well as to kind of transition into adulthood. That also ties over to academics. So it's really not just one specific area that we have to deal with interventions. It's a span of things. So when we talk about what is the best approach to treatment for FASD, some believe it's focusing on the functional problems using strategies that might be for other similar problems. Some are focusing on identifying a specific or behavior phenotype or kind of characteristics that throughout all FASD, and then structure the approach according to the diagnosis. Some may want to use standard interventions that are commonly used for other individuals, such as medications like stimulants for ADHD. There's a group that are looking at specific interventions designed for individuals with FASD. Some may want to adapt successful methods for other developmental disabilities or special needs of individuals, for individuals affected by prenatal alcohol exposure. I kind of want to propose it's going to be a little bit of everything, and we'll kind of see why. Next slide, please. So when we talk about approaches, the National Institute on Alcohol Abuse and Alcoholism, they kind of are the forefront of FASD in the United States. They indicate that there are various approaches that might help reduce the symptoms of FASD and lessen the impact on those affected. These include education, behavioral interventions, and interventions individually tailored to address specific impairments. Also, ways to support their caregivers. And this might include social support, case management, as well as their services for children as well as adults. Currently, there are new interventions being developed. There are prenatal nutritional supplements for pregnant and postnatal supplements for children. These are still in development. One's choline. I'm not going to discuss choline because that is a medical piece and I'm not a medical doctor. Learning and behavior interventions are aimed at improving cognition, daily life skills, and impulsive behavior. We will look at that in the interventions. School-based approaches, which there aren't a lot, but we'll talk briefly about some of those. And we'll also talk about some computer-based games that are being developed. And then we'll talk about a mobile health application, which some are right now being developed, and that's through CFAS. And we'll talk a little bit about that. Now, there are barriers to not only diagnosis, but also that kind of tie into different perspectives. When we take a look at FASD, it is often misdiagnosed or overlooked. Chasnoff did an article in 2015, which was very interesting, which he indicated that in his clinic, many children who were in the foster care either were misdiagnosed or overlooked. So what they found is that 156 who met the criteria for FAS, 125 of those were never diagnosed with an overlooked diagnosis rate of 80%. 31 were recognized as having FASD, but diagnoses were changed. So 6% had a misdiagnosis. So it's really being overlooked. And so that kind of makes it, when you think about how some are saying it overlooks other disabilities, a lot of the individuals affected by prenatal alcohol exposure who are misdiagnosed or their diagnoses are overlooked may not be receiving the appropriate treatment. And this is kind of the challenging piece. Individuals with FASD have a variable presentation. In other words, there's no single behavioral phenotype that's been identified. Some may have a wider range of cognitive impairments, while some maybe have more subtle kind of impairments. Doesn't mean that they don't need treatment. It means it may be misdiagnosed. There's also stigma and misperceptions. In some of the literatures, especially on caregivers in schools, there is a stigma that some believe, especially with some educators, they cannot be taught, or why are we giving them a lot more instruction because of their brain damage, they will not show improvements. Some misperceive FASD as being only behavioral, and that's not necessarily true because it is a range. There are a few professionals trained to diagnose and provide interventions, especially in rural areas. We see that a lot in Georgia. Some believe, and this was an article from Nash and all about 2 years ago, said that FASD does not necessarily deviate or different than other diagnoses. Their characteristics are not enough to be specifically separated from ADHD or other learning disabilities. When you look in the literature, there are subtle differences between ADHD and FASD that can make a big difference when working with interventions. And some believe that behavior problems seen in children with FASD cannot be separated from environmental factors. And I'm going to show you a study and talk a little bit about that more later. So we do know that neurobehavioral traits are very important related to FASD. Often we focus on the neurobehavioral traits because these are those that interfere with functioning at home, at school, as well as out in the community. We know that many have global cognitive impairments, or they may have specific cognitive impairments in executive functioning, working memory, visuospatial abilities, and processing speed. The challenge comes is that no one has the same typical profile with the overlapping cognitive impairments. Often we see emotional and behavior regulation problems, attention deficits, and a lot of poor impulse control. But we also see this with other disorders. We know that there's functional language, which is the ability, they may have good receptive language or isolated language skills, but we have to pull it together and use it to express ideas or to convey feelings. It breaks down a lot of times in children affected by prenatal alcohol exposure. They may be wanting social interactions, but they have difficulty explaining or maintaining social interactions. So that makes it a little tricky for them to function not only in classrooms, but out in the community. Some may have difficulties with daily living skills, despite having even IQs in the average range. And we do know motor skills can be impacted. What gets confusing is that you might have these, you might do a traditional kind of intervention and they may not respond. And that could be due to kind of the specific profile. We do know the effects from prenatal alcohol exposures are brain-based. And so we have to be aware of this so that we can shape the intervention to meet the individual's needs. Now, I mentioned that we say it's environmental. This is a study from Dr. Bowers. He was a psychiatry fellow with the clinic. He looked at the effects of prenatal exposure and adverse childhood experiences, or ACEs. And what they found is that those who had more situations of ACEs, 4 or more, had more behavior problems. We looked at kids ages 1 to 18 years of age. 60% of the participants were under 5 years. And what they found is on the CBCL, or the Child Behavior Checklist, males showed more problems with acting out behavior. However, females' behavior were more impacted by trauma, with a greater number of ACEs related to negative behavior. So the more negative early experiences the child had, the more behavior problems they showed later on. What we did find also is that stimulant exposures, not necessarily alcohol, showed an interactive effect on ACEs on externalizing behavior problems. In other words, when you take alcohol, it goes through externalizing behavior. It had a greater outcome, not alcohol, I'm sorry, stimulant medication. And then when we look at alcohol and other drugs, it was not necessarily a direct relationship, but it added on to the intensity, which I think is very important because environment plays a big part. When you've got brain damage or the effects of prenatal alcohol exposure, that can add on to the intensity of the problem. So it's going to be very important to understand the effects of prenatal exposures and in consideration of other environmental events when we're dealing with interventions for children affected by prenatal exposures. Clear as mud? Next one. So this brings to me is that we really need, when we're thinking about care for children affected by prenatal alcohol exposure, it's a collaborative approach. It does start with a really good evaluation and diagnosis. It needs to consider events in the home, school, and community. So we're not just looking at school or placement at school or classroom interventions or school-based services, which are very important. We also need how to support the caregiver so they can become very, which this group is probably one of the best in the nation from my experience, Form Families Forward, on helping parents become effective advocates, how to support them, and as well as try to make sure that they're getting what they need so they can support their children. We also need to look at not only medical, but also mental health services, rehabilitative therapies, and social case management. That's very important. And regardless at school or at home, training on FASD is very important to understand the underlying impact of prenatal exposures, as well as what the options are to help children. Next slide, please. One thing after looking at the literature, especially looking at literature on caregivers, is some caregivers get very frustrated having to explain to teachers year after year their child's needs. And one thing after talking with teachers, some this summer, was taking a look as they weren't really quite sure. And then when I went back and talked to parents, parents weren't sure how to explain their children's needs. And I think that's something when you're talking about interventions, you don't even know where to start. You've got an evaluation. How do you explain the evaluation in terms not only that parents can understand it, but that parents can use the words and use that evaluation to explain to teachers or to explain to other providers? So before I get started into that, one thing is the perspective of interventions for children with FASD is shifting. We're shifting away from this intervention is strictly for FASD to looking on identifying the strengths, weaknesses, and challenges of the individual and matching how we can improve building skills, how to teach children to be self-determinate and increase their own self-advocacy, increase independence, and how to improve their quality of life. We're still going to address the deficits, but we're not going to just focus on the deficits. We're going to focus on how to work with the deficits as well as to build skills. We're going to increase interventions to target their functioning. So we want to improve functioning with or without support so that they become as independent as possible so that they can participate in their setting. And we're moving away from the focus just on the diagnostic label, though it is important to knowing where to start and how to, the lens on how to view your child, but how to build around that and what your child needs. Next one, please. So I'd like to, one thing we've been looking at here at the clinic and other clinics and clinicians have looked at from the World Health Organization, they developed the International Classification of Functioning Disability Health for Children and Youth. And what they're trying to do through this, and this is not just for FASD, this has been developed for other developmental disabilities. And they've had a lot of luck with this, especially with kids with ADHD and other mental health diagnoses. It uses a common language to talk about ability and disability. Ability refers to an individual's engagement and participation in an activity. In other words, where does a child succeed? What levels or what skills do they have that helps them become engaged, succeed, and enjoy what they're doing? Disability refers to the impairments that restrict that participation. And when we take a look at their environment, their overall environment may be a source of support. So in other words, for example, if a child's at school, they do very well in a self-contained class, that's the environment that's very supportive. A barrier may be kind of on the flip side, when they're in large group settings without support from adult, they fall apart. That means the environment is not matching what the child needs. And the overall goal of the intervention is to build the skills as well as to improve the quality of life later on. We can go on to the next slide. So this is a model when we talk about how to intervention plan for children with FASD, and this is adapted from the ICF-CY. We've got to think in FASD in terms of their neurodevelopmental deficits. We're just not going to get rid of those. But where are they weak? Where are their weaknesses as well as where their strengths? For example, a lot of children with FASD have visuospatial problems. In other words, inability to mentally rotate images to solve problems, but their language is really good. So how do we use that? To use that language to help them mediate their weakness so that they become more active and engaged in the learning so that they can participate. Activity and participation interact. Then we have to look at the environmental factors, setting, demands, expectations. How does that impact not only their neurodevelopmental deficits, are they developmentally appropriate, but how do we use those to encourage their activity and to increase their participation? And one big thing we're finding is that personal factors, children's traits and things that help them or what they prefer can be really beneficial to help them get involved. That includes their life experiences, their family and social support, as well as how do their affinities, because this is where the strengths and challenges come in. There are a lot of children who have, like, they may be good with paper and pencil, they may draw well, they may be very socially motivated. Those are personal factors you can use to support them with any intervention. Okay, the next one, please. And there are tools to help you with this. One is from the Families Moving Forward program. It's called reframing. So when we talk about reframing, we're talking about viewing a child's interactions, not in terms of a good or bad behavior, but in terms of their learning profile and in terms of their neurodevelopment. In other words, if a child has difficulties, become very impulsive, especially in a large group setting, they're not, most of the time, and kids, we're on the belief that kids are not trying to act badly. They cannot, if a child's affected by prenatal alcohol exposure because of brain damage, they can't inhibit that. So it's viewing that in terms of FASD informed care. There's another tool called the Functional Abilities Classification Tool. This one's a little bit more elaborate, but it breaks it down into different levels on a scale from 1 to 4 to say, okay, and it looks at different settings and levels of participation. If you'd like to know more about families moving forward, the website's on the slide. And if we go to the next slide, I'll talk a little bit about the Functional Abilities Tool. Oh, is it not there? Whoops, back. Oh, wow. Okay, let's go on to the next one. Sorry. Okay, so interventions designed for school-age children with FASD. My slides got messed up somehow. Okay, that's okay. Let's go on. Next slide. So looking at all this, let's look at categories of interventions for children with FASD. There are medical, we have medication and supplemental, nutritional supplementals such as choline. I'm not going to discuss those because those are medical based. We have therapeutic, which are behavioral interventions, attention arousal regulation training, and adaptive functioning with motor skills. We will talk about those tonight. There's substance use prevention and treatment from O'Connor. That is something that, again, that's more of a psychologist and a medical provider. So I'm not going to discuss those tonight, but know that there are some out there. We have early intervention. And then there's also academic and learning readiness, caregiver training and support. So the ones in bold are the ones we're going to focus in tonight. So let's talk about self-regulation and behavior. So what we see often with self-regulation, you might observe behavior such as moodiness. Children may have a negative affect or become very irritable when they're in different situations. You might see frequent behavioral outbursts. At the same time, you might have difficulties in coding new information. In other words, they may learn bits and pieces because they're not able to take the information, hold it, and then store it for later use. You might see difficulties shifting attention. You might have difficulty sustaining mental effort. And that's when something, for example, persistence comes into that. And that's something that's needed, that when you get challenging, you can deal with it. And then you might see impaired impulse control. Next slide, please. One thing we have found very effective for children with FASD is teaching them how to regulate. And we call this behavior regulation training. This incorporates typical behavior management techniques into the context of dealing with the neurodevelopmental damage. And what we do is we use social learning principles. We also teach children how to use their language. And we teach parents on how to address and how to perceive a child's behavior. And a key component is to teach children how to regulate their own behavior. On the chart, when you look at arousal levels, really we want behavior in that calm, alert, that middle range. Oftentimes kids, there are certain situations, they may go from there into upset crying. We want to figure out how to bring them back to that calm and alert stage. Next slide, please. So one program is, and this is actually out of our group, is called Go Far. This was developed by Dr. Cable and Dr. Coles and Dr. Ellis Taddeo. Next slide. Go Far, the purpose of Go Far was to improve behavior regulation, adaptive skill, as well as affect. So in other words, we were teaching children how to regulate their own behaviors so they become less irritable. The intervention is provided through a serious computer game. And then they also work with the parent, the child, the parent, and a trained therapist on how to improve their adaptive functioning, teaching the parent on how to address and how to work with the children. The one thing is the series computer game is available at do2learn.com, and I will talk about the basis of the game. But what we're trying to do is teach kids how to approach a behavior, how to approach a problem and solve it systematically. Next slide, please. A key component of Go Far is teaching them metacognitive training. Metacognitive means self-awareness. And what we try to teach them is how to focus and plan, how to be aware of their actions, and when they're done, how to reflect or review upon what they did. We teach them this at the entire session. So before even beginning a session with a parent or even on the computer, we'd say, what are you going to do? We make a plan on what they're going to do. As they work through the computer games, the computer game is designed to have the kids ask the question, to think about what they're doing as they do the computer task. And at the end, they're asked to tell or to think about what they did. So we do that, we plan it out for the full session. And then for each individual task, we do the same thing. This is what we're trying to do is actually build the frontal lobes, which we know that impacts executive functioning and behavior regulation. Next slide, please. So when we talk about these frontal lobe exercises to improve self-regulation, the study, we had a midpoint and a post-test. And what we did is we compared 3 groups. We compared children who were in the GoFar group who not only had practiced with the computer game as well as with the therapist. We had a contrast group, which was a FASD group, which is another computer game that's a serious computer game that taught kids actually to look at pieces of faces and put together to help with their emotional understanding of facial expressions, and a control group. So when we look at the first, the index of disruptive behavior, we did see a pretest for both the GoFar and the FASD group. We saw a significant decrease from the pretest to the post-test, as well as the midpoint testing and behavior. So in other words, teaching kids to start regulating and use this approach themselves actually help them to control their own behavior. And then when we look at this kind of negative affect or this irritability, we did see also a decrease, especially in the GoFar and the FASD group, in negative affect. We did not see it in controls. Next slide, please. So what we also did is we did the test of the variables of attention. And so our pre-test to post-test in the FASD group and the GoFar group, we saw a significant decrease, an improvement in attention. So if you look at the pre-test for the GoFar, it went from a negative 3.48, and that's a standard deviation. Someone who is considered ADHD or having ADHD symptomology is at a negative 2.26. They were significantly higher than ADHD on the symptomatology. At post-test, they were almost within the average range. Response time increased. So in other words, we didn't have that lag. So they responded better, which was an indicative of improved attention. We also saw a decrease in response time variability. In other words, they had more consistent attention instead of that inconsistent. Sometimes they're attending, sometimes they're not. We saw that for both of the groups that received the intervention when compared to the controls. Next slide. So what we determined is that learning to use this metacognitive approach using FAR, and there are other ways to do it, decreased the parents' reports of children's disruptive behavior. We saw a reduction in children's irritability. We definitely saw an improvement in sustained attention. And then when we looked at the Vineland, which is a measure of adaptive behavior, we did see improvements in their adaptive and daily living skills. If you'd like more information about GoFar, you may contact the FAS clinic here at Emory at fasclinic@emory.edu, and we will give you information and we will tell you how to link up to get the computer program if you'd like just to use the computer program. Next slide, please. Now, there are other programs that looked at improving self-regulation with FASD. This is the ALERT program. They did this in Canada, in the United States, as well as Australia. And they found that, yes, there were improvements in self-regulation and executive functioning. What they specifically improved were inhibitory control and emotional and behavior regulation. In other words, they improved this goal-directed behavior, which is a cornerstone of a lot of this. The ALERT program, it's often used with other disabilities. It's also administered by a lot of occupational therapists. So if you have an OT, it may be worth talking to them if you want to use this program, if they can do it. Information about the ALERT program can be accessed at this website. So when we talk about metacognitive training with children with FASD, there are benefits as well as drawbacks. We do know children who use metacognitive techniques have fewer behavior problems, and can accomplish a better sense of control. They increase their own self-control. We know that most children can use this, even children who are functioning in the mildly intellectually disabled range. We have taught them to use this metacognitive approach, and it can be applied across settings. I use it in academics, others use it in social skills. It can be used. It's an approach, it's a framework. The drawbacks, and this is something, is labor intensive, and it is more effective when it's practiced across settings. So it needs to be practiced consistently, because what we're trying to do, and this is the hardest thing to do when children have executive problems or self-regulation problems, is to get them to start using this as a habit. And to build it as a habit, and to do that is you have to constantly improve or practice. Now, there are other ways to improve arousal regulation, attention, and working memory. One is Kernzenal improved attention using the attentional computer control training, which was a computer program. Michaela and all used metacognitive strategies. Again, they used a serious computer game called Caribbean Quest. And what they did is that kids used their strategies spontaneously. So they did start developing habit. And then Loons and all used verbal rehearsal, which is pretty easy to teach. But again, you have to constantly help remind kids to use it to develop a habit, is to improve the recall of information and memory. So now let's talk about some academic skills for children with FASD. Again, this is another one out of our group. It's the Math Interactive Learning Experience. It was originally designed for children ages 3 to 10 with FASD. And the goals were to support, educate, and empower caregivers about the impact of prenatal alcohol exposures on learning, especially in math, improve children's learning readiness, and we focused on behavior and arousal regulation because that has a great impact not only on interaction in the community, but also in schools. And then math it's a common deficit in children affected by prenatal alcohol exposure because of the overlapping cognitive impairments. We use specific instructional approaches in MILE. What we did is we did speed of processing. In other words, we individualized the pacing and the rate of instruction. So if children needed longer time or slower instructional or interaction, we slowed it down. If they went faster, they did it. To improve visuospatial processing, we used manipulatives to give a concrete representation of how the math pieces work together and the concepts, and how's it align with computation. We focused on activities to improve numeracy. This included number recognition, magnitude computation, estimation is something I'm seeing a lot in children with FAS having difficulties with estimation, and that's part of the numeracy. We worked on working memory, giving them interactive exchanges, multiple exposures. We used verbal rehearsal, and we used strategies to help them retrieve and encode information. Visual motor integration was supported using handwriting without tears. This is a common handwriting program used in many schools. They also have a typing program, so that might be something if you're trying to improve that graphomotor skills, that's a good program to use. And departments of education in many states are using it also at their schools. We used attentional control. Again, we did this with direct instruction to identify relevant information, and we taught children to use self-talk to help them sustain that engagement. And we did do metacognitive training. We used the Focus, Act, Plan, and Reflect with MILE too. And what we found was this. This was the original study that came out, and this came out in 2007. What we found is that a clinically significant gain was indicated on math achievement was greater than 1 standard deviation from the pre-test to the post-test on any of our 4 maths. So when we looked at the 2 groups, over 58% of the children who received the math intervention made gains compared to those in our contrast group who did not receive the intervention. They only received only 23% of those made gains in math. So we were saying at our first post-test, yes, 58% of those who received the math intervention did make significant gains. Next slide. Okay, this was from the follow-up study. And what we found on our follow-up study is that these gains remained 6 months after the intervention. So children continue to show gains who received the intervention in the math group, not necessarily the math contrast group. Next slide, please. Now, we also looked at behavior problems. And what we found on parental reports for the behavior problems is that, well, let's talk about the teacher first, and that's the TRF. On the TRF, there was a significant reduction in behavior problems across age groups. When we broke it down even further, we found that there was an interaction. In other words, the time and age, so whether we tested you at post-test 1 or post-test 2, and the age of the child. And what they found is that children who were younger showed a more significant improvement in their behavior. And this was time at post-test 2. And then overall, children between the ages of 3 and 5, or 31% of the children in the study, had a greater reduction in behavior disturbance than the children in the older group, though there were reductions overall. So really, parents as well as teachers reported greater reduction in behavior problems. Next slide, please. And so what Mile is doing now is that Carmen Rasmussen's group in Canada is taking it and has broken it down to be put into the Edmonton City Schools in Canada. And one of the recent studies came out that they looked at Mile at 28 participants between the ages of 4 to 10 years of age. One thing about the original Mile, there was a parent component. The group in Canada is not using the parent component. And they did 2 groups. They did an intervention group and a contrast group. And what they found is that those who had the math interventions made more gains on their math achievement tests than the contrast group. And what they found is that children who were older, lower functioning, those who had PAE but not FASD, in other words, they did not have an FASD diagnosis but a history of exposure, made greater changes in mathematics achievement. What they're kind of figuring is that those who were prenatal exposed but had not been diagnosed either had been overlooked, so they had not received intervention. And so it's not uncommon for kids when they have had no intervention, but to get it to show these increased these rapid increases and kind of level off. It could be that is what they're expecting. But overall, the group who received the math intervention made gains in their math skills. Next slide, please. So kind of our summary, when we look not only of the research studies coming out of our group, but also out of Canada, is that instruction devised to increase the active learning. We address the cognitive deficits and to improve that cognitive control. We showed improvements in learning readiness. We showed not only caregiver, but teachers reported decreases in behavior problems. We also showed improvements in mathematical skills. So if you'd like to know about Mile, and actually we do give away Mile because it was grant funded, we do not charge for it. Please feel free to email me and I can send you all the materials. So we'll go from there. One thing too is people ask about tutoring and does tutoring work? And I'm going to tell you, yes, tutoring works. And there's nothing magical about tutoring for children. Sometimes it's actually the attention. But again, if you use the principles that we've talked about, is looking at where children has their weaknesses, using their cognitive profile to identify strengths to support their weaknesses, making academics on their learning level expectations reasonable, and being consistent, you do see improvements. This is a case study from the Cognitive Habilitation Group for children affected by prenatal alcohol exposure. We run the Saturday Cognitive Habilitation Program here for FASD at Emory. Kids come to me during the school year. They receive one-on-one intervention. We use the Math Interactive or Mile, or we use elements of Mile, especially for the older kids if we have to address reading or if we have to address written expression. This case study was 5 children ages 10 to 6 to 13 years, 8 months. With history of prenatal alcohol exposure. They were all pretty heavily exposed. 2 did not get a diagnosis. Cognitive and academic functioning fell within the deficient to low average range. All but one of the children who were in the study completed all 12 sessions, and all but one received special education services. A big element for those, though everybody received the metacognitive training. We didn't use FAR, we used another very similar one called Plan, Do, Review. Very similar, and I'll show you and self-questioning techniques, and we'll talk about that. Those who needed reading, we used the not yet. Those who needed reading, we used the phonological strategy training, or FASD, and guided reading. Those who needed mathematics intervention, we used mathematics. So what we found is that all but one children who received the tutoring showed an increase at least one standard deviation, which in other words, we were trying to move them from a borderline into close as possible as we could get to within normal limits. All made one big gain in an area of academic functioning from the pre-test to post-test. Several of the kids made gains on the matrix analogies test because we were looking at attention and nonverbal reasoning. And we had some go in from the borderline range into the average range. And this was attributed to the Plan, Do, Review. We increased their attentional control and their ability to regulate and attend and prepare to learn. Now, 2 children showed no significant gains. And this is also kind of goes back to what I was saying about when intervention is implied. It doesn't mean they're not gaining skills. They just might not be gaining at the same speed. The child who showed no significant gains had received the most long-term intervention and was receiving the most continual intervention from school and private providers. This child also had the poorest scores on executive functioning when we went back and looked at it. We did see there was a plateau of progress. But however, when we went back in and looked at the executive functioning at a later date, we did see a slight improvement. So we do know that they can plateau, and it could be due to some of the cognitive levels, but we also know that he still gained skills. Next slide. So when we talk about metacognitive training with self-questioning, we use Plan, Do, Review with self-questions. In other words, we taught children to ask themselves before they even started a task, do they know what to do? What looks familiar? If they can't answer those 2 questions, then we had them ask themselves, do I need to ask for more information? That was the important part for when they asked for help. We asked them how they were doing, and then at the end, we had them review. Next slide, please.
I am going to forward. I just wanted to let you know that we are at 5 minutes till the hour.
I just saw that. I'm sorry.
No, you're fine.
These are academic skills. There have been others for spelling, task completion. It's important that when you give really good directed intervention, kids affected by prenatal exposure will improve. Next slide, please. So when we talk about elements of academic intervention, it's very important to consider the impact of the neurodevelopmental deficits, as well as the level of functioning to determine the appropriateness of the intervention, focus on building skills, maintain realistic and attainable expectations. That metacognitive training, I cannot say it enough, is very helpful, and frequent review and practice to help transfer the skills over. Next slide, please. Adaptive functioning and social skills. 2 I really want to point out is the Bruin Buddies and the Children's Friendship Training. Bruin Buddies, or Best Buddies, was helping kids to learn how to interact with their peers. Parent reports that they had reduced behavior problems and became less hostile in social settings. The Children's Friendship Training, parents reported that kids learn after going through this training, which I absolutely love this program, they learn to use more pro-social behavior. Next slide, please. So if you want to know more, because there are chapters of Best Buddies all over the United States, Best Buddy programs, you can find your chapter and your location by this website. Also, Children's Friendship Trainings out of the University of California at LA, that website will take you to them. Next website, next link. Where am I? The other one I kind of want to point out, which I find very interesting, and this one just came out, is Gleichman et al. In 2022, and this is just a pilot study, and it needs more research. They randomly assigned 20 kids with FASD to a control group or an intervention group and taught them to play the piano on a keyboard. And what they found is that there was an improvement in reaction time and attention measured by EEGs. It's very preliminary, but it's interesting when you look at other literature is that teaching kids, and I'm not passive, but teaching them actually to play does improve executive functioning skills, such as teaching kids to play chess. So that's something to keep in back in mind. And really, if you're thinking about doing something locally, why not? They can play a piano. Next slide, please. Next slide. So the other program I think it's very important is Families Moving Forward. They have therapists all over the country. If you want to know, and this is for parent training and support about FASD, their website is here. In the near future, Families Moving Forward Connect is an app, and it's being developed, and it's hopefully going to be, it's going through its training pretty soon, but it's going to be released soon. And this is an app to really help you parents to connect with others, give resources, and really understand, even reframing how to think about children with FASD and to connect with others. Next slide. Caregiver training and family support is very important. Again, we did it, training caregivers on FASD on how to advocate for education, as well as to understand FASD. And we found that both really parents reported it very helpful, but they also reported that they were able to cope with children's behaviors better after receiving training. Lenars and R did coaching families. They showed pre and post changes on targeted outcomes. Families were satisfied and felt that we're able to work with their children better. It's important to really understand your child's needs because you're the best one, you're the expert on your child. Next one. So we do have current gaps in our knowledge. There are about 20 to 40 studies that really have good empirical basis, but they're very limited in scopes. The behavior interventions are very promising, but we need larger clinical trials. There are very few studies on interventions for children 0 to 3. There are very few interventions on specific ways to address learning and academics, especially for students in middle and high school. Next slide, please. So there are interventions that are helpful that we found with other developmental disabilities or learning problems. If you want to know more about executive functioning, the Harvard Center on Developing Child is a great resource. Cooper's and all the zonal regulation curriculum, they use this in a lot of schools. It's a good way to help kids use colors and to recognize our signals to learn how to start self-control. And then Coping Cat, especially for older kids, if used with a therapist, is very helpful on ways to help kids learn how to deal with things when they become difficult. Next slide. Positive behavior interventions are very helpful. And when I say positive behavior interventions, it's teaching them the skills and the tools on how to respond appropriately and providing positive feedback. Parent-child interaction is geared for younger kids, but it's very helpful in helping kids to become more compliant. In some cases, applied behavior analysis may be very helpful. Next slide. For thinking problems, the University of Kansas strategic instructional model is very helpful. It helps not only with problem-solving skills and thinking habits, but it can break it down on how to do specific academic skills. They also have strategic math series, which ties very closely in with the MILE. It's been effective for older kids. If you want reading intervention or guidance for that, the University of Florida Literacy Institute is a wealth of information. It can also connect you with other resources to kind of support your children for reading. Next slide. So really, in summary, and I'm sorry I'm rushing at the end, but I want to value your time. We're moving away from just matching to a diagnostic label. Though the diagnosis is very important to really consider a frame of how your child's, what is happening with your child is almost the etiology. We want to focus interventions on building and applying skills. They need to be developmentally appropriate. We need to encourage caregiver involvement and teach you on how to also help your kids so they can help transfer it over. It's to improve self-independence independence and self-determination. In other words, teaching them how to do it across settings. Again, it's collaborative. And we also know that children, often interventions may be lifelong, but they'll be adjusted or have to change as children develop. From the clinic, and I've got to say this, I've got several kids the kids that come through our Saturday clinic, I have better than an 80% high school graduation rate with a full diploma. The kids really knock it out. They can do well. And I've got kids who are severely impaired and holding jobs through vocational training and are happy and are coming and are telling me that they're proud of what they do. The kids can do it with the right support. And I thank you for listening. And I'm sorry for my snafu, and I'm more than willing to take any questions you might have. Oh, these are just some articles if you're interested. And I am more than happy to send you any articles or information you might, that might be helpful.
Wonderful. Dr. Millians, thank you so much. We are a little bit over time, so I just want to point out, and we'll let, if you're willing to stay on for a few minutes, if we'll just double check if there's any questions, but those of you who have to run, Stacia has put in the chat box the evaluation link, and we do appreciate you taking time to just click on that and fill that out. It does not take long. Stacia, do we have any questions?
I do not see any right now in the chat, but people can drop those in if anything has come up for them.
I do have a question, actually, Dr. Millians, about obviously hugely appreciative of all of this information. It is so good to know that there are some interventions out there that have been proven, because we sometimes, as parents, particularly get a little frustrated when we feel like we've tried and things are just not moving forward, and you get in that, you're tempted sometimes by that discouraging, nothing's going to work sort of a frame. So because we know that it is a significant impact, the prenatal alcohol certainly can have a significant impact. So it is nice to know there are some promising practices. I was curious where these interventions are being implemented. Have you found any characteristics of places, schools, centers that are more likely to adopt these, and how do you incentivize implementation of these practices? Because I know that's a big lift for some schools.
Yeah, exactly. What we have found is some of this, which is interesting here in Georgia and is throughout the state, some of the school-based mental health services are implementing some of the behavior techniques. They implement some of the positive behavior interventions. There are, if you go to your community mental health or psychologist and look up PCIT, there are a lot of therapists who are trained in the PCIT, and that's actually, they've looked at that too briefly in some children with FASD and showed positive effects. Georgia's a little different than some other states. With some of the schools, if parents would go to the school, we've found here that we've gone to them, we say we need certain kind of interventions. They've done it. After school tutoring, miles being implemented in, from what I understand, San Diego, at one of the schools, and some of the schools in San Diego school system. And then if a lot of some of the tutoring or some of the after school programs are a good place. I've been interested in miles, especially here in Georgia. A lot of it is just your individual school and finding like your community mental health or a foster parent or foster care group who provides services, which some do, who are willing to implement one of these programs, and you can get the training. Yes. I hope that answers the question. Other than that, there's not a lot.
Yeah. No, I hear you. And I think that's, the context in which the school sort of operates its framework for managing behavior is definitely could be a barrier, or it could be a real protective factor for some of our kiddos. So I think you raised some really good points.
And again, I don't know about other states. Georgia is very decentralized. So we've got one school who may do it, and in the same district, another school who won't. I know schools in New Mexico, there's a school system in New Mexico that's actually using a lot of these approaches. They're doing mile and they're interested in Go Far. And then Go Far, the computer program is on dotolearn.com. And if you're interested, you can go ahead and we can send you that information.
Yeah, that's huge. We can, and again, all of the slides are in our on our website, and you can link to those and find the links that Dr. Millians provided, and we will have a recording of this. So thank you. Let me just make sure there's nobody else who stayed a little later if they have any immediate questions. I know it is late, and we hope to see you a week from tonight for our final in the series. Stacia, had any last words?
No, I just wanted to extend my appreciation to Dr. Millians as well. I think that the slides that you have provided are just a wealth of knowledge, and I can spend a lot of time going through and researching some of those things myself. So thank you for that. That's such a valuable resource. So thank you.
Well, thank you for having me. And let me know if there's anything you need from my end, and I'm happy to, if there are questions later, please just let me know.
Great. Thank you so much. And good night, everyone. Appreciate your time.
Thank you.